Okay, so we are going to start the session for this. Okay, so we've got some questions. Let's run through them. In case of tongue tie, is it really important to release the tongue, even if it doesn't interfere with the stage one appliance? Or is it enough to simply expand and control the posture? Many people say that releasing the tongue is vital for success of the treatment. What is your opinion? Um, so again, I think it's very important to um, differentiate between posture and function. So again, to re-clarify, function are movements of the body in space to achieve a specific task. Posture is the position held in space, right? The position you hold your body in space. And they're related, but they're different. One is a movement, and the other is non-movement. They have different purposes, and they affect the body differently. Right? Physical movement in space is an action that breaks the cells down. Right? So any movement will cause cellular action and associated damage. Posture, which is the resting state, is when there's no specific cellular activity for movement and is the time for repair and growth and development. A tongue tie can restrict function, but is less associated with the posture. Right? Whether you have a tongue tie or not will have a very big impact on the functional movements, but a much smaller impact on the resting posture of that tongue. The resting posture of the tongue is relevant for what we are trying to correct, with the concept that optimal resting posture of the mouth is with the lips together, the teeth in near or light contact with the tongue on the hard and soft palate, and also connected with the floor of the mouth and touching the lingual surfaces of all the teeth. If you have a tongue tie that stops you from moving your tongue so that you can eat or speak, then it's something that needs to be addressed and should be released accordingly. If your tongue tie interferes in comfort with the stage one appliances, then it should be addressed so that it's comfortable to function and rest with the appliance in place.
Simon, sorry to interrupt, but you're not sharing screen.
Oh, okay.
Thank you.
All right. So all it is the written question. So if the tongue tie does not prevent the child from resting with their lips together, the teeth in light or near contact, and the tongue touching the palate, the teeth, and the floor of the mouth simultaneously, then I'm not particularly concerned about the tongue tie interfering with correct rest oral posture. I found in my practice a grade 4 tongue tie does often prevent the child from being comfortable with the stage 1 appliance and makes it very, very difficult for them to achieve correct resting posture. I tend to find that grade 3 tends not to be interfering, and I'm not fussed about a grade 2 or grade 3 tongue tie, but I'll always refer to get the tongue tie released if it's a grade 4. So that's just been my own experience. So if they're a grade 3, I tend to um, make a judgment. Is it a 3-4 or is it a 3-2 or is it a 3? How do I judge that? It's like the tie should be at least 4 millimeters from the tip of the tongue. If it's at least 4 millimeters from the tip of the tongue, then I normally leave it. After I've done my development, I will then assess the child's capacity for normal speech and check to see if they can do the suction hold GoFX exercise. If at that point they still have a speech difficulty or they can't um, rest with their mouth closed and the tongue on the palate, then again, I'll send them off to get the tie released at that point in time. So that's usually what I do. So grade 4 tongue ties tend to be very disruptive for both function and posture. Grade 3 tongue ties tend to be disruptive for function, but not usually for posture. So we reassess a grade 3 after. We will refer a grade 4 for release before commencing postural orthodontic treatment. A grade 3 we will assess after arch development is completed to see if their function is still affected and if their posture is not achieved despite the arch development and the training, and then we'll get them to go get a release. I'm never really concerned about a grade 2. Okay, next question. Which Ceph is the ideal method to use? Tweed, Steiner, or McNamara? So I'm assuming which Ceph analysis is the ideal method. The answer is there's no ideal method for cephalometric analysis. That's why there's like 20,000 versions. Each of them are favored by different orthodontists. who have different interests in different aspects of growth and development and treatment um, training. I have a basic focus on cephalometrics. My interest for cephalometrics is the position of the maxilla, the position of the mandible in AP relationship. I'm interested in the vertical growth pattern, and as such, the reference measurements that I'm interested in is A and B. So SNA, SNB is of interest for me. That gives us an indication of the sagittal dimension, whether the maxilla is forward or back, whether the mandible is forward or back, and the relationship of the maxilla to mandible, whether it's class 1, 2, or 3. I'm interested in widths because that can sometimes help me gauge the dental relationship, which is useful for determining whether we're class 3. I am interested in FMA and Y-axis to help me discern the vertical growth pattern. And I'm interested in the level of tip and proclination of the incisors so that I can determine if it's a division 1 or division 2 relationship. Those particular interest points for metrics appear in the Eastman analysis. So if I was to recommend one analysis that I would favor, then perhaps the Eastman analysis, the British analysis. And many of the measurements that they are interested in, I am also. But can you use anything else? Of course, or you can use whatever you like. So long as you understand the relationships that they explain in the analysis. Doesn't actually matter what you use, so long as you know how to interpret and understand those metrics that the analysis provides. So long as you understand each of the analysis that you favor, then use them. It really does not matter which one you use, so long as you use one of the recognizable universally accepted versions and that you understand what those metrics signify and mean so that you can explain what the skeletal relationship is. Please explain about horizontal growth type, which results in a flat body of the mandible. So when we're talking about sagittal and vertical growth, we have a basic universally accepted concept of direction of growth of the jaws. To simplify, we would say we're either growing in a horizontal direction or we're growing in a vertical direction. Or we might say we have a forward rotation of growth or a backwards rotation of growth. So we recognize Angle's classification as to the relationship of the maxilla to the mandible in the sagittal relationship. Okay, so class 1 is where the maxilla is very slightly ahead of the mandible, with both maxillary teeth and mandibular teeth all kind of intermeshing in a bite relationship. We recognize a class 2 relationship with a maxilla that's slightly ahead of the mandible, to a point where the interdigitation of the teeth is not anywhere near as nice, and we have an excess over jet relationship. We subclassify this as a division 1 or division 2, and we recognize this according to the proclination of the incisors, either a tipped relationship in a division 1 or a retroclined relationship in a division 2. We recognize class 3 relationships where the mandible is ahead of the maxilla, but we have a subcategory which is not as often talked about, but one that is roughly classified as a low angle and one that is classified as a high angle. So a low angle is where we have a reverse bite that has a over bite relationship, and a high angle is where we have an anterior open bite relationship in the class 3. And that gives you a clue as to what we would call horizontal growth versus what we would call vertical growth. Outside of the angles classification, we also recognize what we call a hyperdivergent or a skeletal open bite or a long face growth pattern, where skeletally the jaws are growing in divergent relationships, with the maxilla kind of growing forward and the mandible growing down, and the incisors not meeting nicely in a closed bite relationship where predominantly it's just back teeth that are touching. We've also got another subset where we've got an overclosed relationship, where we've got a deep bite in the incisor relationship and a hidden posterior open bite. So horizontal growth is where the FMA or the y-axis is closed, or there's less vertical growth, and we've got less of a gonial notch evident in the mandible. Our growth tends to be further forward, and so we'll have more sagittal space for back teeth to fit. Horizontal growth, where you have a low angle in the jaw, can be class 1, it can be class 2, and it can be class 3 low angle. You've got a normal growing or large mandible growth and a deficient maxilla, and a deep bite, a class 3 revert, cross bite. So how does that come about? If you rest with your posture being correct, lips together, teeth together, tongue on the roof of the mouth and the floor of the mouth simultaneously, then growth has a vector that follows the closing rotation of your jaw. So when you bite your teeth together and close your jaw, the chin rotates up and forwards. And so that creates a movement or a moment or a vector of force that is up and forwards. In the Bjork classifications, that's called a forward rotating growth pattern. And forward rotating growth patterns tend to be predominantly horizontal, the growth pattern. When you have your mouth open, then the chin is pulled down and back, and that has a backwards rotation, and it tends to increase the gonial notch. So the mandible tends to be less square in its relationship, and you have a greater divergence. So backward rotation is associated with more vertical growth. And you have less squareness in the jaw, so you have a more vertical growth pattern. The reality is everyone is in kind of like a mixed relationship where the growth is a combination. It's not at right angles, it's not a vertical drop, it's closer to 45 degrees roughly. But you can still get a reasonably square mandible in, that type of 45 to 28 degree relationship. The closer you are to resting well with lips together, teeth together, tongue on the roof of the mouth during that nighttime sleeping growth period, then you will grow to have a fairly square mandible jaw relationship. And that's square from the perspective of vertical ramus to horizontal ramus relationship. So you get that flat body of the mandible from the angle all the way to the symphysis. So mouth closed in a closed rest posture tends to lift the chin up, and then you'll get growth that is a forward rotation, and the angle of the mandible from the vertical to horizontal ramus is closer to like a right angle, and hence you'll have a flat plane from that angle of the mandible through to the symphysis. The more your mouth is open, the greater the pull downwards and backwards on the symphysis, and you'll get a divergence in relationship between the horizontal and the vertical ramus. So you'll get greater gonial notch, and you'll get a greater increase in vertical dimension. The variability is if it's just your lips together but your teeth apart versus everything open versus lips together, teeth together, but tongue off the palate. So generally when we rest with no freeway space, lips together, but tongue off the palate, then you'll get a clenching type relationship and you get overclosure. And you'll get too square or a kind of acute angle relationship rather than a square angle or an obtuse angle. Okay, last question, unless someone adds something. In an 11-year-old girl with half erupted canines, could we treat with postural orthodontics? So 11, like 11 What does that mean? Well, normally the lower permanent canines come out at around 10 years of age, and the upper canines come out at around 13 years of age, plus minus a little bit. So I don't know if we're talking about lower canines or upper canines, because it has an impact. We know if the lower canines are erupting, then we have begun the final late mixed dentition. If we're talking about upper canines, then we're coming out of final mixed dentition and moving into full permanent dentition. If it's the lower canines about coming through, then we have still got 2 years, or no, probably 18 months of transition remaining. Right? So if we're 11, then we've still got 11 and 12 to get through. Right? Are we brand new 11? Are we halfway through 11? Are we at the end of 11? Right, because 11 is 12 months, right? 365 days. So if we've just turned 11, then we got 2 years before the upper canines. And if we are towards the end of 11, then theoretically we've only got 1 year before the upper canines come through. Why is that important? Well, everything is also tied to the stability of the primary second molars. So they're the teeth that we tend to rely on for the anchor abutments for your postural orthodontic appliances. So for the treatment to have good success, you want the ease, the second primary molars, to be stable during the expansion phase. So when do the ease change over? Well, the general sequence of changeover in the late mixed dentition is lower canines, then upper first premolars, then lower first premolars, then upper second premolars come through, and then the lower sevens come through, then the upper sevens come through, then the lower second premolars, and then finally the upper canines come through. So they all occur approximately 6 months apart from 10 when the lower canines come through. All right. So that's your general timeline. So what does that mean? It means that the E's are going to be stable until about 12, 12 and a half. All right. So the upper E's will exfoliate at around 12 and a half, and the lower E's will exfoliate around 13, or in some cases, 6 months earlier. Okay. So if theoretically, if you're at the start of year 11, you've still got a year to 18 months with the lower E's, and you've got about a year with the upper E's. Okay? So your question is, can you do what you need to do with the time that you have with the E's solid? That's basically what it comes down to. And I'm talking about, um, biological age as opposed to chronological age. So that's the story. If you don't have enough time to do what you need to do with the E's being stable, then you'll start something, but you'll have no way of finishing it. So if the ears aren't solid and you don't have the expected time that you need for your treatment, then you'll put your appliances in, you'll start expanding, but before you've achieved your dimension goals, then the ears will exfoliate and you'll have an appliance that won't be retentive and you can't expand when the premolars are erupting and the 12-year-old molars are erupting. Right, so that's basically what it comes down to. Um, when the premolars, when the second premolars are beginning to erupt, you also got your 12-year-old molars pushing through, so you need closure of a leeway space in order to achieve the correct molar classification and uh, provide room for the 12-year-old molars to come forward. So that's why we can't actively treat during the very late mixed dentition period. If your ears are solid, then you've got to determine how much development do you need, how many millimeters do you need, and then you've got to determine how long will it take me to get that arch development. And then you've got to remember the upper is expanded at 0.8 millimeters every 8 days, and the lower is expanded at the fastest would be 0.35 or 33 millimeters every 8 days if you're moving at the correct rate. The lowers sometimes don't expand at the rate that we want in the late mixed dentition because the bone is hardening and you can't sometimes expand in older children at the same rate as you can in younger children. So sometimes you have to slow the lower expansion even more. And so you've got to determine if we are only developing 0.35 millimeters every 8 days, am I going to achieve my goals of the required transverse expansion with the time I have left anchored on the ease and the ease when will they exfoliate? So that is for the transverse development. Now, postural orthodontics also has a component which is retraining posture. Retraining posture is utilizing the GoPEX and the GoFEX exercises. Unless a child is in crossbite, GoPEX can be done at any age and every other malocclusion. So nothing usually stopping you from retraining a child with their GoPEX exercises. So the reality is you get more bang for your money by changing someone's posture than you get by sticking in appliances in their mouth. So if we were to say what is the most important part of postural orthodontics, we would easily be able to confirm that it is retraining from a predominantly open mouth resting posture to a predominantly closed mouth resting posture. And retraining someone's posture is only hindered by a nose not passing air cleanly through into the lungs and an occlusion that creates a traumatic situation when in the fully closed position. GoFX, which is what creates the vacuum seal, however, can only be achieved in those who have a class 1 or a mild class 2 relationship. So you're limited if you have a severe class 2 relationship, or if you have a class 3 relationship, or a vertical growth relationship. So if you have a milder malocclusion, you can retrain that child, irrespective of whether you have any other appliances in or not. You can't sometimes idealize the retraining, but you can take significant measures to improve the posture of an 11-year-old with half erupted canines. All right, so that is all the questions that we have, and that's all we're going to talk about. So wishing everyone a Merry Christmas and a Happy New Year, and catch up with you in 2026. Thanks for participating in these sessions. All right, Merry Christmas.